it's Dr. Tofi. Welcome to HerniaTalk Live. I'm your host, Dr. Shirin Tofi, hernia and laparoscopic surgery specialist. You all are joining me via via Facebook as a Facebook Live. Some of you are here via Zoom. Thank you for coming. So today I plan to answer all your questions and try and focus on specifically hernia surgery techniques and how important it is to have a surgeon who does a good hernia surgery technique to maximize your outcomes. And the reason why I picked this topic is because this past week and a half, I would say almost 2 weeks, I've had multiple patients who came to me who had, I don't want to say completely the wrong operation, but it's an operation I would not have done. And the reason why that surgeon did that technique, I'm not sure of why, but it was the impetus for their complication. And if you talk to other experts, they would agree with me that probably it's not the best choice of surgery. And so I thought we should discuss this because we talk about seeing an expert, mesh versus no mesh, how you deal with complications, and so on. And we often don't understand that even if someone is offering, quote, let's say laparoscopic surgery, there's different techniques in doing those operations. And it's important that the surgeon do that operation with a good technique. Because even though if you look at all the literature, it'll say, oh, shoulder ice is very safe and has good outcomes, or laparoscopic surgery is safe and has great outcomes. The technique is important. So two surgeons can be doing a quote shoulder ice repair or a quote laparoscopic repair with completely different outcomes because their technique is very different. And that's what I've noticed in the past couple of weeks. I thought would be a good topic. So I'm here for you. Send me all your questions. Many of you have submitted questions online, so I have those posted and we'll go through those as well. But I just want to share some stories. So this past couple of weeks, we've had some patients who had laparoscopic repair and now they're miserable. And many of you who know me online know that I'm a fan of laparoscopic surgery in general because it is less invasive. In other words, less cutting and sewing. It's actually a bigger operation on the inside for inguinal hernias, but it's not as much cutting and sewing, and so the recovery is easier. There's less incision to heal from. Laparoscopic surgery is also great for the abdominal wall. Again, lower risk of infection, and especially with robotic technique, there's a lot that you can do similar to open without having to open. And so the morbidity and the complications related to laparoscopic surgery are definitely there, but with a good technique, the outcomes are really, really good. So obviously I don't recommend the same operation for everyone, but for the average patient, laparoscopic surgery is kind of the preferred technique. And I use the terms laparoscopic and robotic a little bit interchangeably because they're often similar in technique. However, I've had 3 patients in the past week and a half, and hello from Houston, thank you. The past week and a half that have had a laparoscopic hernia repair, groin hernia. The patients had inguinal hernias, little bulge, little pain, and they underwent laparoscopic repair. And it sounds like the patients were super excited because their surgeon offers laparoscopic surgery. Well, the technique used is what's called the Keyhole Technique, and it's highly, highly not recommended. There are different techniques for laparoscopic inguinal hernia repairs. Specifically, the Keyhole Technique is not recommended. It is a technique which replicates the open surgery technique where the mesh has a keyhole in it. It's basically slit. It's like a slit technique is another term for it. And it's wrapped around the spermatic cord in men, or sometimes the round ligament in women. And that's how the hole is patched. So most of us that do laparoscopic or robotic inguinal hernia repairs, we place the mesh against the hole as opposed to wrapping the the opening of the hole with the mesh, which implies wrapping the mesh around the spermatic cord or the round ligament. Why is that different or not a good technique? Well, primarily it's because it's kind of like a Goldilocks issue. So it can be made too tight or it can be made too loose. If it's wrapped around the hole too loose, then the hole is exposed and then you can get a hernia again. If it's wrapped around too tight, then you can actually impinge on, erode into, or otherwise kind of like strangulate the spermatic cord and its contents. What are the contents? Blood vessels to and from the testicle, the sperm coming from the testicle, and the nerves associated with it. So if you obstruct the blood flow, then you can have testicular pain and swelling and bulging. If you impinge the nerves, you can get testicular pain. And if you obstruct the spermatic kind of flow, you can have testicular pain and pain with orgasm. So, and pain with ejaculation. So none of those are good options. And how does the surgeon know if it's too tight or too loose? You can't make it too tight initially because all these meshes shrink. So the lightest weight meshes shrink about 10%, the heavier weight meshes shrink about 25%. So how is a surgeon to know exactly how tight or loose to make it initially, so that in 6 weeks when it's shrunken, it'll be perfect? Hard to do. So that's the reason why we don't like the keyhole technique. Another reason also is the muscle that protects a lot of these things from happening doesn't exist in the laparoscopic space. It does with the open space, not the laparoscopic space. So it's completely bare to the mesh, and something that is not a good idea. So I've, like I said, 3 patients in the past week and a half that had the keyhole technique, and now they have testicular pain, they have obstruction of their testicular blood flow, they have groin pain, it's very uncomfortable for them sitting, some of them can't work anymore. It's just not cool. And then I'm thinking, okay, well, I know that you're not supposed to do the slit technique anymore, and yet there are surgeons in my town who do it. There are surgeons outside this country who do it. Like, why? Somebody taught them, or they chose to learn it. Kind of, they're more comfortable with that technique because it's actually easier. You have to do less dissection, and they're used to that technique because it's an open surgery technique. But here's a problem. You as a patient, how do you know? How do you know if your surgeon's going to do the keyhole technique or the slit technique as opposed to the typical laparoscopic technique, which is for inguinal hernias, which is an quote onlay. So either laparoscopic or robotic, it's an onlay technique or underlay technique. So you don't, and it's really hard to expect and put the onus on patients to ask those questions. How do you know, like, what questions to ask? Even let's say I needed an inguinal hernia, presumably I'll find a surgeon whose technique I know, but I might most likely will assume that surgeon is not going to do the slit technique, because in my world, as a hernia expert, we know not to do that, but you just can't assume. And I'm hoping to discuss all of this with you all to come up with some type of consensus as to how you as a patient can best protect yourself from bad or wrong technique and get the best repair from your surgeon. So here's a couple things that I recommend. And we've done a whole episode on what questions to ask your surgeon during your consultation. We did another episode talking about how to find the right surgeon for you, and like who's like the right, like what's an expert? How do you know your surgeon is an expert? But my thought is this. First of all, you should always do your research. So nothing is just a hernia, even a little belly button hernia. There's tons of ways of fixing those hernias. So you should kind of read up on it, go to the forums, patient forums, HerniaTalk.com is an excellent one. We talk a lot about everything on that forum. And what's really cool about HerniaTalk.com, which is a website for my podcast here, is first of all, it's free. It's a free discussion forum, but also we have really smart members who are constantly perusing the web and YouTube and share videos and agendas from surgical meetings and discuss like what other surgeons have said and so on very openly. I learned a lot from it myself, to be honest. So do some research. Then I would see more than one surgeon, even if you think it's an easy thing. Every time I've needed surgery, I've definitely seen more than one surgeon, even though I probably know like who to go to. I still think it's important to get another person's, perspective. Everyone's got a different perspective. So let's say you see multiple surgeons, right? How do you know that their technique is good? First of all, I think personally that in general, if a surgeon is a bit obsessive compulsive, and or like kind of put together, most likely that's also represented in their surgical technique. There are surgeons that I know of, they're always disheveled, their hair is always messed up, coat jackets are either dirty or sideways. They tend not to be the best surgeons, I would have to say. I can't say that for everyone, but usually the surgeons that are well put together, clean nails, clean office, well-run office, and they're ask a lot of questions of you, are actually interested to know more about your symptoms and more about your lifestyle and support system and all these other things that are important as part of surgical recovery. Those tend to be better surgeons too, because they understand that all those little details will eventually affect the outcome from their surgery. So those are like little things that I pick up on. If a surgeon's dismissive or doesn't want to answer your questions, comes in and kind of talks at you, not with you, those are red flags where, at least for me personally, I would not want to go to a surgeon who's like that, because I feel that they need to kind of treat me like I'm the most important thing at that point and not be distracted and or to kind of discount, oh, it's just a hernia, discount my needs. So that's one thing where those are like little clues, right? Secondly, I would say that you should have a series of questions, and surgical technique is one of them. It's hard to ask, like, okay, so what mesh are you going to put in, and what technique are you going to use? What suture are you going to use? At some point, it starts to become a little bit too intrusive with the surgeon, and you're kind of prying into their specialty and not trusting them. But you know what? Who cares? I say, who cares? I say, if you can ask these questions politely, respectfully, show that you're anxious about your outcome, and you've read that there's a keyhole technique and the regular technique. What do they think about those two, for example? If they're like, oh yeah, I use a keyhole technique every time, I would leave the office. But if they say, yeah, a good question. No, we think the online technique is superior, and that's the technique that I use, or something like that. Or I use absorbable sutures or tacks or permanent sutures or tacks, whatever the situation may be. Then those are good. If you have a surgeon that sits down with you and actually tries to answer as many questions of yours as they can, that's usually a good sign. And then the question is, how active is this surgeon in the surgical community? Because what I notice is most of these surgeons that I have seen do these poor techniques. So I just gave you an example of one poor technique, which is the keyhole for inguinal hernias. Other poor techniques would be like they use way too many tacks. I took out, there's a patient I just operated on. I took out like 24 tacks from this patient, 24, and he still had like another 24 tacks left in him. Completely inappropriate use of tacks. You don't need that many tacks for like an abdominal wall hernia. And tacks are these kind of like screwed in fixation devices that we use instead of suturing. It works very well if used sparingly, but to completely, shoot the abdominal wall with all these tacks can cause pain. So I had to go in there, individually remove them. And like he had several other tacks kind of floating in the belly, that's just sloppy. So those kind of surgeons, I always want to know who the surgeon is, read the operative report and so on, but they're usually surgeons that are not that interested in hernias. They don't come to the meetings. I go to all the meetings, so I know who's at the meeting and who's not. If I don't see you at the meeting, to me, that means you don't really have an interest in hernias. They may not be reading. We have tons of texts, textbooks and journals and newspapers that talk about hernias all the time and quote consensus papers and quote expert papers and so on. All of these are readily available to all surgeons. You just have to have the interest to read it. And yeah, surgeons that I see that these patients have complications from tend to not be the ones I assume that are reading, because if they were reading, they would know not to do the keyhole. If they were reading, they would know that more than a certain amount of tacks is inappropriate and can cause pain. And then lastly, like how active are they to publish? So when people publish, I feel that they're inquisitive, right? Why do people publish? They look at their data, they have a question, a research question that they want answered, and it shows inquisitiveness. You have a query, you're interested to know more. And people who publish tend to have that kind of personality where they want to learn more, do better, and so on. Also, one detail that most people don't understand about publishing is you can't publish without doing research on other people's publishings. In other words, let's say I do a paper on mesh removal, right? I did a paper on laparoscopic versus robotic mesh removal. It's a pretty good paper. I can't publish that paper without including other literature that has discussed chronic pain, mesh removal, laparoscopic surgery, robotic surgery, etc. Just the act of me going through the process of finding literature that can support or contradict my findings and including that in my introduction discussion of my research, that alone makes me a better surgeon because I now have increased my knowledge. I've read more, I've done more, and I've accessed journals that I may not have accessed before. So people who publish also tend to be more knowledgeable, and when they're more knowledgeable, hopefully that translates to being a better surgeon because they won't do certain things. So here's a great question by one of you, the audience, which is a plug and patch method common? Great example of a horrible technique. We used to think this was a good technique. A lot of times techniques come and people get all excited about it. The plug and patch was one of them. It was a way the Lichtenstein hernia repair was already considered the gold standard. It involved a scar. It involved a lot of sewing, and the plug and patch kit that came originally from Bard, but then also from other companies, including Ethicon, and I think, if I'm not mistaken, Atrium, as competitors. The whole thing was you don't need to cut and sew as much. You don't need to have as big of an incision. Just focally focus on the area and just plug the hole. And you need very few stitches. And so the incision is smaller, and therefore the risk of infection is smaller. And the surgery involves less cutting and sewing, so that it should have less pain afterwards. And it actually worked really well. I got trained in doing the plug and patch my first year out of residency, and I started doing it for several years. I don't do it anymore because I learned, and other experts learned, that it doesn't really make a better repair, but it does add to the risks for the surgery, because you're putting in a big globule of mesh in the patient's groin. In thin people, they can feel that globule, that ball of mesh. We call it meshoma. In larger hernias, the mesh can flip around. In athletes, they can be hindered by their range of motion because of the plug. If it's not sutured incorrectly, again, technique. So, some surgeons were putting in only two sutures instead of 3. Other surgeons were putting in absorbable suture instead of permanent suture. These little changes to the original way of how it was designed came up with poor outcomes. Some surgeons were using small and medium-sized hernias for these meshes for these larger hernias. Again, the correct technique is to use large for most indirects, and extra large for most direct hernias. You have to match the size of the plug with it. And then the original way where it was designed was to literally plug the hole, but then it was later revised to kind of be opened up a little bit, so the back side of the mesh is not poking into your bladder, rather it's kind of flattened out and gives like a little bit of a kind of an extra mesh repair. And the problem with it was they sold this mesh like it was candy, and there wasn't enough focus on surgeons correctly placing this product. And so to this day, most people use the plug and patch incorrectly. So they use absorbable suture, they use the wrong size of the plug. They put too little sutures, 2 instead of 3, for example. They don't open up the posterior patch, and they use it in like the wrong size patient. And therefore, they had a lot of complications. So now you have people that were totally okay, they had a little hernia, they got this plug in them, and it's like their whole world has changed because the plug is now eroding into their bladder, pushing into their psoas muscles, so they can't like bend or sit. It's migrated and so on. So it's been one of the worst designs when it was used across the masses. You got to have a mesh design that every type of surgeon in every type of country with all types of skills can use without causing harm. And this was not one of them. This is one of those meshes where, unless you use it as an expert, the chances of doing it incorrectly were high, and therefore it's a bad mesh design. So none of us really use that mesh anymore because it's unnecessary. The Liechtenstein repair open is a perfectly good open repair, and there's no need to use that. But again, technique is important. I put in tons of plug and patches early on. I don't recall having, I think I had one I had one patient who had a problem with it, and he was morbidly obese. The hernia was really big, and I probably never should have used that plug on him to begin with. But most patients did very well. And the surgeon who was kind of the leader in it from Rush University, really good surgeon, Dr. Milliken, he had really great outcomes. The patients did really well. But then you had this mesh sold everywhere with very little education, understanding about the physics of how this mesh works. And then now all we do is take out the plugs because it's considered just unnecessary mesh. And that mesh is still being sold. In fact, I think it's dropped in the amount of being sold, but at one point it was the highest volume mesh being sold by any company in the world. And that may have been its downfall. because of the way that it's designed puts the patient at risk of using the wrong technique and therefore having a poor outcome. So a lot of these meshes that come out, the technique of putting it in is important. And because of the way that it's designed, if you don't do it correctly, you can actually cause harm. And that's usually a bad mesh design. The PHS, or purling hernia system, is another type. It's a bilayered, or not bilayered, two-layered mesh, which when placed by the original surgeon, Dr. Gilbert, who designed it, Art Gilbert, or other experts who do it really well, it worked really well. But then you had surgeons using it thinking they just kind of shove that mesh in there, and then the mesh would ball up like a plug. That was not the intention of the mesh. And patients would have similar pain problems as did people who had plugs in. So technique is very, very important. And I must say, it's not just mesh related technique, it's also tissue related technique. So shoulder ice repair is a perfect example. A lot of surgeons don't offer the shoulder ice because the technique is actually quite complicated. You have to understand your anatomy very well. And if you don't, you can have a higher risk of chronic pain, hernia recurrence, and damage to the nerves. So with tissue repairs, you have to know what you're doing. There's a Marcy repair, for example. It's a very simple tissue repair used on children and small hernias on women. It's just simply closing the hole. There are other surgeons that have come up with different techniques. They're constantly helping like improve it. But unless you're showing me your data and saying, here's how the technique I did from January of this year to the January of next year, and then I saw I was getting recurrences, and therefore I improved it and made it, and now for another year I did this other technique, and here are my results. Unless you do something like that, it's not cool to just kind of randomly make up a technique on your own and hope that it'll work because you think it's going to work. You need to, as a surgeon, I would say, as a surgeon, you need to be very upfront. And let me tell you, if you're experimenting with different techniques, at some point your patient kind of needs to know that the technique you're using is not the real shoulder ice or the real Marcy or the real Bassini or whatever the technique is, but a modified version of it. Because the studies that are out there that say, let's say shoulder ice is a great technique, is because everyone who's in that study has performed that technique perfectly, exactly how Dr. Schuldeis intended, exactly how the technique has been perfected, and they're not messing around by changing the type of suture or doing 2 layers instead of 4 layers and so on. I've seen so many operative reports. It kind of pisses me off. I see so many operative reports by surgeons who tell this patient, oh, I did a shoulder ice repair on you, and you're reading the report, and either the surgeon has no idea what the anatomy is, or they have no idea what a shoulder ice repair is, because it's completely wrong in the way that they're documenting what they did. And then the patient has either chronic pain or hernia recurrence, nerve injury, or something in that realm, and that's just not cool. So when you talk, let's say you want a tissue repair, right? Or you've been told you should get a tissue repair and you go to a surgeon. Well, it's important that they explain to you, are you doing what kind of technique they plan to use? It's okay to ask, like, is it permanent suture or not? Or, is this like the original technique as described? How do you, oh no, we modify it. Oh, how do you modify it? Again, be very respectful with your surgeon, but at some point, you don't want to be the one telling the surgeon what to do. That's, I think, inappropriate, because you need to find a surgeon that you trust, and at the end of the day, know that they're going to do a good job. But prior to that, during your consultation, at least get some feedback from them to prove to you how they're going to do the best job. Does that make sense? I hope that makes sense. It's a fine line. It's a fine line. A patient of mine, her name, she wrote a book called, what's the name of the book? It's a patient help book. I posted it before. It's a really great book. It tells you the Take Charge Patient. That's the name of the book. The Take Charge Patient is a great book. I give it as gifts sometimes during Christmas, but it takes you as a patient through all the different steps on how you can access the right care without being that patient that no one wants to take care of because you're just kind of asking questions without a purpose and being really disrespectful about it. So it is a little bit of a fine line, but the right surgeon would be the one that is okay being questioned respectfully and is there to make sure that you feel confident in their practice and technique, because at the end of the day, on the day of surgery, you want to show up, all your questions are answered, complete confidence in the surgeon, know that they'll do the right thing, and then have an excellent surgical outcome. And that's the goal. But you got to put the time into it before surgery to get all those questions answered. Let's see. I'll give you another example of what happened. The patient, I feel so bad. These stories are horrible because I get all these stories sent to me and I'm trying to help patients. Some of them I can't help anymore because they're kind of already had the damage, but there's so many patients out there where I'm kind of like, when I read their story, it's kind of forensic to me. In other words, I'm trying to figure out like what I would have done differently or how I would have interpreted this pain differently. And there's just one patient that had completely wrong diagnosis. So they had a hernia repair with this keyhole technique, right? Then they had a completely wrong diagnosis for why they have the pain. But the doctor who was treating him was so confident in saying, oh, this is your problem, but was completely wrong and took this patient down this completely wrong pathway, got the wrong procedure, the wrong procedures to help with his pain. And now is like, has had multiple spinal cord stimulators. I mean, it's just ridiculous how much misinformation and mistreatment he's had since that one failure by his surgeon. And I'll preface this, and let me tell you, I've had my own complications, so I'm not claiming that experts or others don't have complications. However, once you do have a complication, it's almost like this rolling ball of you're at risk for more complications or more delay in treatment and more procedures necessary to kind of get to the end of it. So this poor patient had keyhole mesh technique, which is a no-no laparoscopically. No one can figure out why he had the pains that he did. He's now being told he's got nerve pain, which he doesn't really have, because you can't even have like ilioinguinal nerve pain after laparoscopic inguinal hernia repair because the nerve is not there to injure. Anyway, it's complicated, but he's being told all these different things, and eventually I've seen patients that were told, oh, you need your testicle chopped off. Yeah, no, you do not. You almost never, 99% of patients will never need their testicle removed as a complication of hernia, period. Like if they tell you that, you gotta get a second, third opinion. Okay, sorry. Let's move on. Okay, here's a question from one of our viewers. All right, it says, I had left inguinal hernia surgery with mesh and a plug in Minnesota in 2015. Yeah, there we go, the plug issue. The minute I hear plug, I think meschoma, where you can't sit, or kind of erosion into adjacent structures. When we went to Arizona for the winter, 6 months later, I saw a surgeon in Arizona. He said he was going to do exploratory surgery to see what was causing my pain. Wrong answer. Exploratory surgery is almost never necessary. The combination of history, physical exam, and imaging should be able to answer why you have the problem in the majority of patients. I'm going to say more than 90% of the patients. You do not need to go in there and just take a look or see what's going on. That's completely wrong. It means that surgeon does not understand what's going on. Okay, sorry, let's move on. He said he was going to do exploratory surgery to see what was causing my pain. He removed the mesh and plug, but replaced it with the new mesh and plug. What? Wait a minute. Are you serious? What? They took out the mesh plug and patch and then put another one back in? That makes absolutely no sense. No sense at all. It's like, oh, you have pain in your foot. Let me I'm just gonna look in your shoe, see what's wrong. Oh, look there's a pebble in your shoe. I'm gonna take out the pebble and I'm gonna put another new pebble inside. That makes absolutely no sense. I'm sorry. This is stuff that pisses me off. Okay. He removed the mesh and plug, but replaced it with a new mesh and plug. I'm still in horrible pain. Of course you are, because you had the wrong operation. Plus, I have 3 more hernias and I refused surgery because they used mesh. Mesh is not your problem. It's the plug and the technique. It's going back to technique. Don't blame the mesh quality itself. The actual fact that there's mesh is not the problem. You probably do need mesh. It's the technique and the decision making. Okay. I was going to come see you 2 years ago when we wintered in Arizona, but some druggies burned our house to the ground in the summer, so we didn't return to Arizona. I wish you were here in Minnesota. I wish you were here in California because I can help you for sure. The plug and patch operations are one of the most satisfying mesh removal operations because it's literally like removing a pebble from the shoe and the patient's like, oh, so much lighter, better. They don't have whatever it is from the mesh plug. Okay. Next patient with the question. I went into surgery exploratory and woke up with 6 hernias repaired with mesh. Never was asked if this was okay. Okay, I don't know why people are getting all these exploratory surgeries. I assume you're being consented to have a certain operation. Like maybe you have a hernia, we're going to fix it. I don't understand this exploratory. I went to surgery looking for adhesions. Oh, okay. Just had my new CAT scan and I have more hernias. I'm not sure if I will use a new surgeon. That makes no sense. So you had exploratory surgery and hernias repaired, although they were looking for adhesions. Just had my new CAT scan and I have more hernias. I'm not sure if I will use the new surgeon. Yeah, get another opinion, please, please. And remember, I offer online consultation, so even if you can't like travel for surgery, sometimes it's good to get a second opinion, even like virtually. So send me your stuff, I'll review it and give you kind of my advice about it. And sometimes you can take that and move on to get the best kind of plan of care by someone near you, but at least there's some guidance. Okay, next patient. I had open surgery without mesh for my left inguinal hernia 4 months ago. Now I have another inguinal hernia on my right side. Is it okay to have laparoscopic with mesh on the right side? Yes. Is there any chance that laparoscopic surgery on the right side will increase the possibility of recurrence on the left side? No. Okay, so that was easy. Oh, in response to to that plug out, plug in situation. Wow, my story is similar with the first part. I had plug and patch and pain from day 1 back in 2014 with chronic pain over 6 months. The surgeon then acted like I was crazy and was not in pain. Unbelievable. That's a red flag, by the way. If your surgeon is blaming you for your pain, move on. This is like your girlfriend or boyfriend saying, I'm just not that into you. Don't try and force them to date you or be into you. They're not. Cut it off and move on. The surgeon then acted like I was crazy and was not in pain. Now, over 9 years, I am back in chronic pain and with bad nerve pain in the groin, testicle, and lower abdomen. I'll bet you have a hernia recurrence. I think that's what's going on for you. Oh, did you have the mesh removed? If you had the mesh removed, you probably have chronic pain, recurrent hair. But if your pain went away and came back, that's a hernia recurrence. These are easily treatable, by the way, guys. You don't need to suffer. Yeah, sorry, it's complicated. I never knew I had hernias in the past. Yeah, this whole idea of exploratory surgery really kind of pisses me off too. I'm kind of pissed off today. Sorry, guys. Ugh. It's kind of the reason why I chose this topic was because patient after patient came to me with this damn keyhole technique, which should never be used. And I was just bombarded with people wondering why they had problems with their laparoscopic hernia surgery. And there are people online, many of them are on HerniaTalk.com, which are poo-pooing laparoscopic surgery, not understanding that there's different techniques, right? There's the keyhole and non-keyhole. There's the right technique and how you handle the meshes and so on. So just because an expert says the laparoscopic repair is the best doesn't mean that every laparoscopic hernia repair out there is performed perfectly. And that, or that you as an individual would do best with laparoscopic surgery. So that's kind of a distinction that I hope people understand, because there's a lot of negativity out there and they're saying, oh, laparoscopic surgery is horrible or mesh is horrible, never have that. It's not true. It's just each individual patient has their own. I'll give you an example. It's like saying cars are horrible because people die in car crashes, and look all the gas guzzling and so on. But you know what? Some people, cars allow them to go to work every day, transport them here and there, or they make money off of their car. Other people maybe are like 90 years old and shouldn't be driving a car because it's dangerous. So anyway, okay, so the person who had the mesh plug and patch is afraid to move forward or anything. You should not be afraid. There's a handful of us that treat people like you for a living, and it's very good to know, at least know your options. Like, what is my diagnosis? Is it the mesh? Is it the plug? Is it the technique? Is it do I just have a hernia recurrence? And then at least you'll know, and then we can discuss like the pros and cons of what will make you better. Okay, one more question. I have a confirmed early groin indirect hernia with fat in the sac and was recommended watchful waiting. My question is this: is it okay to delay the surgery with the fat? Yes. And have the moderate discomfort. Isn't the fat stuck in the sac making the surgery even harder when I come to have it? No, it's totally okay to sit around with a hernia that's what we call minimally symptomatic, that has fat content in it. Totally okay. The fact that there's fat in it or not, or does not change how difficult the hernia repair will be. And having a hernia for 1 day or 1 year or 10 years doesn't necessarily make the hernia repair any more difficult. So don't worry about that, which is why we have what's called watchful waiting. And they watched patients from 0 to 10 years. And the patients that were 10 years out and needed surgery did just fine. So there's no need to worry. What I hope is the more you educate yourself and ask these questions, whether it's here on Hernia Talk Live, or it's on HerniaTalk.com, or it's with your surgeon, that education is power, information is power, knowledge is power, and therefore this fear goes away. I see so many people online that are fearful, and it's their fear that prevents them from getting the care they need, and they have a horrible quality of life. And then some of them end up having surgery, let's say with me, and then they're like, oh, that was it? Oh, well, I should have done this so much earlier. Yes, you should have done it much earlier. I can't force you to do it much earlier. It's your choice, your life. But at some point, it's important to just educate yourself, get all your questions answered, and then do whatever it takes to improve your quality of life. I'm a big advocate of that. I wanted to also talk about surgical technique as it relates to how busy the surgeon is. So some people think that a busy surgeon is a good surgeon and a not so busy surgeon is a not good surgeon. Not necessarily true. So up to a point, you want to have your surgeon to have a lot of experience doing things. But once they've done, let's say, 1,000 hernias or more, doing 2,000 or 5,000 is not necessarily going to make them that much better of a surgeon. However, the quality of the surgery now is very important. So you want them to have that experience under their belt. 500 to 1,000 hernias would be excellent if you can find someone with that much experience. But there's a balance between quantity and quality. There are some surgeons that pride themselves in doing thousands of hernia repairs, and they're just horrible surgeons. They just don't care. It's another hernia to them. They don't sit down with the patient. Everyone's treated exactly the same. It's like a factory. And they've done it the same way their entire life. They've made no improvement. Many of them are open technique surgeons that only do one type of hernia repair. And the patients go see them, they only offer them that one type of hernia repair. And so that may not necessarily be the best for you. So my suggestion is this: at least see 2 surgeons and figure out what technique will best be tailored for your needs. And then if you want to stay local or do so within your network, let's say you have insurance problems, or you want to go to that higher volume surgeon, then know that whatever that surgeon is offering you was the right decision because you talked to other surgeons about it. I hope that makes sense. Let's see, more questions. Thanks, everyone. Okay, I'm seeing a surgeon to have surgery in September. She looked at the CAT scan and did not see a hernia recurrence. I'm just seeing her again now because I have right pain and burning. She reviewed the CAT scan again, examined, and said it could be possibly a small hernia on the right side. My issue is very complex and it's a long story. I even have been to a pain clinic that was recommended by my first surgeon. I found out she's a general surgeon but specializes in breast surgery. I never had a block in my area of my first surgery, and now pain is all the way down my leg and now limping at times. Okay, limping is almost never a hernia-related problem, and pain below the knee is almost never a hernia-related problem. So if you have new onset pain or problems that go below your knee or you're limping, you have to look at things like your back or your hip. Limping is often because of the hip. Oh, the first surgery was on the left side in 2014 with the plug and patch. Yeah, so in general, if you've had a hernia repair and you had problems, but it got better, and then you had a period of time where you were without problems, and then now you have problems again, usually when there's a period of time when there's when you're fine and then you have pain, that's usually a hernia recurrence until proven otherwise. Oh, here it is. New patient. Hi, I'm just out of the hospital. Hi, just out of hospital, and the absolute fear you're talking about is very real to me. I have abdominal wall polypropylene mesh and now appendix problems, and the surgeons are not willing to operate because of the mesh. Okay, that's BS. There's tons of ways to get rid of an appendix in someone who's had mesh, because it's not like 100% of your abdominal wall has mesh in it, number one. And number two, surgeons have to deal with issues. So if you can get better with just antibiotics, that would be ideal. And antibiotics are considered a good treatment for most people with appendicitis. So if you have appendicitis and it's an infection and you can get antibiotics and forego surgery because you have mesh nearby, that's fine. However, you can have mesh in your abdominal wall and still have surgery, including appendiceal surgery. So I don't know why your surgeons are so scared. I would be scared if they're scared. See, that it's never good when your surgeon is scared, because then you should try and find a surgeon that's not scared. Limping happened from the nerve block. Nerve block limping related to nerve block only lasts about 6 hours at the most. So If you have permanent limping, then that's not from the nerve block. Okay, let's see. We talked about quantity versus quality. So last thing I want to share is another story. I had a patient who's very particular and very knowledgeable about what they need. And the problem was this: the surgeon who addressed the patient didn't come prepared. So the patient did their job, they did all their research, they sat down and had all their questions answered by the surgeon. But the surgeon showed up that morning, didn't look at their notes, didn't clarify all the little things that were discussed during that he would or she would do during the surgery. And then that surgeon didn't do everything that was planned. That is not ideal. It's usually not a problem. Most people don't have complicated situations, but like for me, I try and write all these things down, because if I see you on day one and your surgery is 3 months from now, I'm not going to remember all those little details that we discussed, especially if it's a complicated situation. So I write those down, because then 3 months from now, when I see you for surgery, I need to look at my notes and kind of review the little details that we found. And that is why I say an obsessive compulsive doctor or surgeon is actually good. I'm a little OCD. I think about things a lot and I try and perfect things. I'm not so bad where I'm like turning lights on and off and not stepping on cracks and stuff. I'm not like that. But I am very detail oriented. And I feel that you really need I think that's a good thing for a surgeon. And the surgeons that I admire a lot often tend to be the ones that are like super smart, but really understand the details of the crux of it, and not the ones that are just flippant and cavalier and just kind of wing it. What I hate the most are the ones that just want to operate and not think. And I think that's not a good trait for a surgeon, because you want to be that surgeon that is a thinker. And I'm a big fan of thinkers. And doers are good. If you're saving a life, you want to be a doer, right? You just go in there and save a life. So trauma surgeons, they got to be doers. It's good to be a thinker too, but that comes secondary. But when it comes to elective surgery, you want to be a thinker. And then not everyone needs surgery, for example. You know, one question that was asked, was submitted, was a kind of a very simple question, which is, doesn't everyone follow the same technique? Like, isn't the Schuldeis, like everyone does a Schuldeis the same technique, or when they say laparoscopic hernia repair, it's the same technique? The answer is no. It's the same way, like, does everyone tie their shoelaces the same? No. Does everyone hold their pencil the same? No. Does everyone put on their socks the same way? They don't. So that is why when people say, oh, you're going to have open surgery, you're going to have Liechtenstein, you're going to have laparoscopic inguinal, you're going to have a laparoscopic IPOM or TAR, whatever, they may or may not be talking the same language as what is considered standard. So for those of you that are interested in the online consultation, all you have to do is just contact my office. All my information is online, but just email me info at BeverlyHillsHerniaCenter.com. It's a mouthful, I know. Info at BeverlyHillsHerniaCenter.com. My nurse, you all know her, Nurse Bell. She's the best. She's the best hernia nurse specialist in the world. There are very few hernia nurse specialists, or maybe less than 5, and she's definitely one of them. But just contact my office directly, and they'll take you through the whole process of getting all your records and setting up an online consultation and getting your images and your story. I need to know your story. Pictures will be good. I have a hernia health questionnaire you have to fill out, which is very kind of directed towards hernia stuff. And it's for those of you who can't come in to see me and don't live in California, we have to do this as a what we call online. So I don't have the ability to practice medicine outside of California. So I don't feign to be your doctor. I'm just there to kind of give you advice and have all your care taken by your doctors wherever you are. So it's more of like an advisory thing. I'm not like treating you in any way. So that was a mouthful. That was a really, really exciting hour I just spent with you guys. I'm sorry, sometimes I get into these into these kind of hang-ups because I see back to back like 2 or 3, 4 episodes or examples of things that go wrong, and I wish that I could help. Like this poor patient that I told you about that had the wrong technique operation and then the wrong procedures to help him with this pain, and now it's been 5 years, 7 years, something like that, 6 years. I so wished that I could have been there to help him from day one, because what he had initially was actually not that difficult of a problem. It's a little complicated. Not everyone can do a mesh removal after a keyhole. It's actually the most difficult keyhole mesh removal after keyhole technique for laparoscopic inguinal hernias is probably the most difficult and challenging of all the mesh removal procedures, but it works really well because it's like being strangulated and then you release the chokehold. It's that impressive in some patients. So here's another question. Are McVeigh and Bassini techniques good? Yeah, all the techniques are good. It's just a matter of whether your specific situation warrants it, and again, technique. So does your surgeon really know how to do a Bassini or McVeigh technique? Don't ever go to a surgeon and say, oh, I want a Bassini. And they'll be like, what's a Bassini? You don't ever want to tell the surgeon to do an operation that they don't know or are not comfortable doing or aren't very skilled in doing. Don't ever force your surgeon to do something they can't do. That's a horrible situation. But yes, McVeigh, Bassini, Scholdice, Marcy, Nihus, these are all techniques that have aged well and are very, very well good techniques, but it depends on the type of patient, the type of hernia, and also the skill of the surgeon. And you may or may not be a good candidate for any of those operations. If you have a femoral hernia, Bassini doesn't work, for example. You need McVeigh, and McVeigh is a little bit of a tight repair. So if you have a big, if you're morbidly obese, McVeigh is not a good technique. These are all like little details that a good surgeon who's done these operations before understands the whole menu of hernia operations that can be performed, which one is best for you, can kind of go. So that's all I have for you all. I hope that was helpful. I had a lot of questions submitted, but I didn't get through most of them. But we always have another week. So thanks everyone for joining me. We have a lot of guests coming up, some international. I'm really excited about those. The international ones, if they're too far away, time zone wise, I try and change the time so that they're not obliged to be up in the middle of the morning. So be very careful about the time zones that I send you the invites for. Do subscribe to my YouTube channel. We got tons of subscribers. I want you to be one of them, because all of these HerniaTalk live episodes and all the prior ones, over 140 of them, are archived there. You can watch them. You can search for keywords to see what specifically you want to look up. If you want to look up Bassini, look up Bassini, and the episode where we talk about Bassini comes up. So hope to see you again at the next HerniaTalk live. It's every Tuesday. Hope to see you soon, and have a great evening. And thanks everyone for all your questions. Take care. Bye.